Good morning and welcome to the GW Epilepsy Grand Rounds. Our speaker today is a world-renowned expert in the psychiatric aspects and comorbidities of epilepsy. Professor Andres Scanner is professor of neurology and psychiatry at the University of Miami Miller School of Medicine, where he directs the Epilepsy Center. Dr. Kanner received his medical degree from the National Autonomous University in Mexico, and then did a number of clinical training programs, starting with psychiatry at Long Island Jewish, and then fellowship in child psychiatry at NIH, residency in neurology at Mount Sinai, and then epilepsy fellowship at the Cleveland Clinic. He was at Rush University for years before he joined the University of Miami, and he's published extensively on all aspects of epilepsy, but specifically on the psychiatric comorbidities and psychiatric aspects of epilepsy, psychogenic non-epileptic seizures, and psychiatric complications of epilepsy surgery, which is the topic of today's talk. Dr. Kanner has received a number of awards, including the J. Kiffin Penry Award for Excellence in Clinical Epilepsy from the American Epilepsy Society. He's edited and published a number of books and numerous articles in major neurology journals. Dr. Kanner.
Thank you, Mohammed, and it is a great pleasure, an honor for me to be here giving grand rounds, and hello to everybody who is in the other rooms throughout the campus. So I'm going to be addressing a topic that I think is of great relevance for any of us who are involved in the surgical treatment of epilepsy, and in particularly in temporal lobe epilepsy surgery. And those are the psychiatric complications of epilepsy surgery. Let me just point out of the upcoming events here. I have no disclosures to make for these presentations. So the learning objectives of these presentations are to recognize the most frequent psychiatric complications of epilepsy surgery, identify the variables associated with the risk to develop psychiatric complications of epilepsy surgery, and recognize the patients at greater risk of developing post-surgical mood disorders following anterior temporal lobectomies and laser ablations of mesiotemporal lobe structures. And you will be receiving CME credit for participation in this event. Okay, so let's get to the topic. So psychiatric complications of epilepsy surgery are one of the complications that one has to discuss with patients when they are found to be candidates to undergo temporal lobectomy or frontal lobectomy, whatever. Unfortunately, among all the different potential complications that can occur with these procedures, it is often under-recognized by epilepsy centers, and very often patients are not often advised as to what is the likelihood that they could experience any type of psychiatric complications, and patients following the surgical procedure may become depressed, anxious, and sometimes even develop psychotic episodes, and it becomes a surprise. These obviously has significant implications in patient care. And so what I'm hoping to do during this presentation is to highlight the fact that this is not an infrequent occurrence, and that it is something that we all need to be aware of when we are offering this kind of treatment to patients with intractable epilepsy. I'm going to focus the discussion for patients who have temporal lobe epilepsy, and as this is the most frequent type of epilepsy that is treated with surgery. So the impact of epilepsy surgery can be seen from a psychiatric standpoint at various levels. First, one can see an impact on post-surgical psychiatric comorbidities with the development of de novo psychiatric disorders, or an exacerbation in severity of a pre-surgical psychiatric disorder, or recurrence of a pre-surgical psychiatric disorder, or a remission of pre-surgical psychiatric disorder. So it's not all bad news. As you will see in the course of the presentation, a significant percentage of patients who were symptomatic before surgery undergo temporal resection, and then their psychiatric disorder remits. And there can be an impact of a lifetime history of psychiatric disorder on the post-surgical seizure outcome. Now, I'm not going to discuss that point because of time constraints. I'm just going to focus on the psychiatric complications and the remission of psychiatric disorders following anterior temporal lobectomy and ablation of mesiotemporal structures. Let's start with the bad news, the psychiatric complications. And I'm going to show an example of a case series from when I was at Rush University Medical Center of 100 consecutive patients that we studied very carefully. This study was aimed to determine the frequency of de novo psychiatric complications following an anterior temporal lobectomy, to determine whether epilepsy surgery reactivated or worsened a prior psychiatric disorder, to determine whether post-surgical psychiatric complications differed among patients with mesiotemporal sclerosis, cryptogenic temporal lobe epilepsy, or lesional temporal lobe epilepsy. So as I said, we included 100 consecutive patients who had refractory temporal lobe epilepsy, and they had to have at least 24 months of follow-up in order to be included in this study. All of these patients underwent a volumetric measurement of mesiotemporal structures. Now, we defined the neuropsychiatric disorder as any psychiatric disorder not identified prior to a temporal lobectomy. First, it could be the first psychiatric disorder ever, or in patients with a past psychiatric history, it could be a psychiatric disorder that was different from those reported before surgery, such as a paranoid psychosis in an individual who may have had a prior history of depression. An exacerbation or recurrence of a previous psychiatric disorder was defined as any psychiatric disorder identified prior to surgery that recurred after surgery following a symptom-free period of at least 1 month, that was, if present immediately before surgery, required the reintroduction of a psychotropic drug or an increase in its dose or a change to another psychotropic regimen. And this is demographic and seizure data of the 100 patients. As you can see, the larger group was the group of patients with mesotemporal sclerosis. Notice the mean age was in their 30s, and the duration between the seizure onset and the time that they had surgery was 15 years, which is a tremendously long period of time that today should not be accepted. We define treatment-resistant temporal lobe epilepsy after individual has failed 2 or at the most 3 trials of antiepileptic medication at optimal doses, so it doesn't take 15 years to identify those patients. And so I encourage you to just keep these data in mind in order to refer patients as soon as you identify that they are likely to be refractory for evaluation in an epilepsy center. Notice that the lifetime history of psychiatric disorder was high, 56 patients, so 56%, 1 out of every 2 patients had a lifetime history of psychiatric disorders. of which 26 had only depression, 21 had a mixture of depression and anxiety disorders, and 12 had other varieties of psychiatric disorders. This is the post-surgical outcome. Class 1A means no seizures, no auras, no disabling seizures and auras. So this is the optimal outcome we aim for. So that happened in 40 patients. 1B means only auras, but no disabling seizures, and that occurred in 20 patients. 1C means that patients had breakthrough seizures after discontinuing medications, but then became seizure-free, and that happened in 23 patients. Class 2 meant 2 to 3 seizures in a year. Class 3, more than 90% seizure reduction. And Class 4, less than 90% seizure reduction. We had follow-up period of 8 years in these 100 patients. Now, this is the slide that I want to focus on. Notice that 41 patients met our classification of post-surgical complications, of which 15 patients had de novo psychiatric events. Of those 15 patients, 9 presented in the form of de novo depression and or anxiety. 4 patients experienced a psychotic episode. 2 patients experienced a somatoform disorder. And 7 patients experienced psychogenic non-epileptic seizures. Now, among these psychogenic non-epileptic seizures, they were included also among patients who experienced a recurrence of the mood disorders. And by that, I mean patients in whom we had to change the psychotropic medications, and despite multiple changes, they continue to be symptomatic up to the time of the last contact. Of those 16 patients, 15 presented in the form of depression. 1 patient had a psychotic disorder. 1 continued to have a somatoform disorder, and 1 continued to have psychogenic non-epileptic seizures. So if I were to be talking to a patient in my office and advising him about the different potential complications of epilepsy surgery, I would include the explanation that they have an increased risk of experiencing psychiatric complications, particularly if they have a previous history of mood anxiety disorders or other psychiatric disorders, with an average risk of 30%, and they have about a 10 to 15% risk that these psychiatric complications can be persistent. When we looked at the variables that could be associated with the development of these psychiatric complications, a de novo exacerbation of pre-surgical psychopathology was one, failure to obtain gainful employment was one, and failure to reach seizure freedom from disabling seizure was one. Lifetime history of any mood disorder was also another one. When we did a multivariate analysis, a de novo psychiatric episode and exacerbation of pre-surgical psychopathology were the 2 variables associated with these phenomena. Now, psychogenic non-epileptic seizures is something that we see in every epilepsy center, and the occurrence of de novo psychogenic non-epileptic seizures is something that has been reported by multiple authors. Luckily, it's not a frequent phenomenon. In this case series, there were 7 patients. We believe that these were de novo, although we can't be 100% sure that we may have not missed them at the time of the pre-surgical evaluation. And what we found is that the patients who developed psychogenic non-epileptic seizures had had a previous psychiatric history. And that was a significant variable associated with the occurrence of psychogenic non-epileptic seizures. Interestingly enough, working after epilepsy surgery was not associated with the development of psychogenic non-epileptic seizure, which was a surprising finding, because very often we assume, well, you're now seizure-free, you have to face the world, you have to take over responsibilities that you were not having. And if you're having a hard time doing that, you may be at risk of developing psychogenic non-epileptic seizures. That did not happen. The variables that were associated with the development of psychogenic non-epileptic seizures were persistent disabling seizures, post-surgical worsening of pre-surgical psychiatric disorders other than the psychogenic non-epileptic seizures, and pre-surgical lifetime psychiatric history. That means that these were patients who already had a significant psychiatric disorder prior to the time of their surgery. And when we looked at the relation between psychogenic non-epileptic seizures and post-surgical psychiatric pathology, that was definitely something that was seen. And it was actually in the form of severe psychiatric disorders and persistent psychiatric symptoms at the last contact, other than the psychogenic non-epileptic seizures. So in essence, having psychogenic non-epileptic seizures, I think, is an expression of an individual who is suffering from significant psychiatric comorbidity, and it's not just a reaction to adjustment to a life without seizures. When we look at the literature, there have been a variety of publications on post-surgical mood and anxiety disorders, not too many. And the problem is that people are yet not placing enough emphasis on these phenomena. And the reports of these post-surgical depression and anxiety episodes vary in frequency from 10% to up to 60%, depending on the methods used and the timing in which the evaluation was carried out. But the average, the message to take home is that the average patient who undergoes a temporal lobectomy has about 30% chance of experiencing a psychiatric complication in the form of depression and or anxiety disorder within the first 3 to 6 months. And in a significant number, these episodes will remit by the end of a year, with about 10 to 15% of patients having persistent symptoms. Now, can patients at risk of post-surgical recurrence or exacerbation of mood and anxiety disorders be identified? And these are 5 studies that I listed here. The numbers in this case series are pretty good. And what you can see is that in 3 of the studies, a pre-surgical history of depression was identified. In the 4th study by Kohler and collaborators, having ictal fear was associated with the development of post-surgical depression and anxiety. And one study from Japan by Kanemoto found that if you had a prior history of post-ictal psychosis, you were at increased risk of developing post-surgical depression. But the main message to take home is you could potentially suspect who is at increased risk of developing psychiatric complications if you look for a lifetime psychiatric history. And here I have to emphasize that it is essential that when you do an evaluation that you're looking for not only the presence of current psychiatric disorder at the time of the pre-surgical evaluation, but of a lifetime history. Because as you know, mood, anxiety disorders, attention deficit disorders are episodes that come and go. This is not something that disappears. People with panic attacks will have clusters of panic attacks for a period of time, then go in remission, and then months or years later, they come back again. The same thing with mood disorders. So it's not enough to give the patients a screening instrument to identify if they have symptoms of depression at the time of the evaluation. You need to find out if they've had in the past episodes of depression, anxiety, psychosis, etc. The other variable that I think is essential to look for is family psychiatric history, because family psychiatric history is a very strong predictor of psychopathology, particularly in the first degree relatives. And we have seen patients with a family psychiatric history who do not have necessarily a previous psychiatric history who may experience post-surgical psychiatric complications. Obviously, to do this kind of evaluation, it is important that it be a psychiatric evaluation. In most centers, this kind of data is acquired by the neuropsychologist. And I want to emphasize that a neuropsychological evaluation and a psychiatric evaluations are two very different things. They complement each other, but they're not the same things. Most neuropsychological evaluations will screen for symptoms of depression and anxiety, but most of these screening instruments will identify symptoms in the previous 2 weeks prior to the time of the pre-surgical evaluations. They will not give you a lifetime psychiatric history. And this, I think, is pivotal data in order to identify those patients at risk. The other point that I want to make is you don't need to be a psychiatrist to do a psychiatric evaluation. You just need to have some understanding of these concepts and ask the proper questions, such as, have you ever had episodes where you felt extremely depressed and anxious? And describe the symptoms of depression and anxiety. And is there any family history? Your parents, grandparents, cousins, uncles. It's not rocket science to do this, and I emphasize you do not need a psychiatrist to do this. How about de novo mood and anxiety episodes? And here you can see the prevalence rates of de novo of mood and anxiety disorders. And it ranges anywhere between 13% to 30%. As I said, those are episodes in patients where there was no prior history of this type of disorder. Now, can we identify people who are at risk to develop de novo mood and anxiety disorders? And there is a number of studies now that are being published in the literature that look at the structural characteristics of the limbic structures in predicting which patients may be at risk. So there is this study by Pope where they found that patients who developed de novo post-surgical depression following a temporal lobectomy had smaller bilateral gray matter volume in orbitofrontal cortices and ipsilateral singular gyrus and thalamus. A study by Wrench from Australia found significantly smaller hippocampal volumes contralateral to the resection among patients with mesiotemporal sclerosis, but not in patients with non-mesial temporal lobe epilepsy. For de novo anxiety disorder, there is a study by Haley that revealed resection of an ipsilateral amygdala of normal volume associated with postoperative anxiety only in patients who underwent mesiotemporal resections, regardless of seizure outcome. So it's a variety of findings. I think the field is extremely new with the use of these neuroimaging techniques. Hopefully in the next few years we will have much more data that we can apply in this regard. What about laterality of the seizure focus and the risk of developing psychiatric complications? So of 7 studies, 3 reported depression more commonly after left temporal lobe resection. 2 studies reported more common after right, and 2 studies had no correlation. So we don't know. Okay. Now this is going to be different in the data I'm going to show you in the ablations. How about post-surgical depression and seizure control? And there is a consensus that post-surgical depression and anxiety are less common if there is complete seizure freedom. And this study by Kellett clearly shows that those patients who are seizure-free, which are in the white bars, score less in all the scales of depression, anxiety, affect balance, mastery, and self-esteem. Post-surgical suicide obviously is a pretty serious complication, and it occurs more frequently among patients who undergo a temporal lobectomy than the expected suicide rate in the general population. So this is a study of 360 patients from 5 epilepsy centers who underwent a temporal lobectomy during the 5-year and had a 5-year follow-up. 27 of these 360 patients died, and 4 were the result of suicide. The standardized mortality ratio was 13.3 for these suicides, so clearly higher than expected. And this is something that you need to factor in when you discuss the post-surgical psychiatric risk with patients with epilepsy, because if you don't tell patients and family members of these post-surgical psychiatric complications, it can have medical legal implications. If a patient goes and commits suicide and the family says, well, you never told me that depression could be a complication of surgery, I would have never agreed to my spouse having this procedure, you could be in serious legal trouble. So what's a summary of the data for post-surgical depression and anxiety? So they're likely to occur in approximately 30% of patients undergoing anterior temporal lobectomy. Most depression and anxiety episodes are diagnosed within the first 3 to 6 months. Symptoms may appear after the first 2 weeks, and they may persist for periods ranging between 6 and 12 months. Up to 15% of patients are likely to suffer from persistent depressive episodes, which may be severe and fail to remit to various therapeutic interventions. And while some authors have associated persistent post-surgical symptoms of depression with failure to achieve a seizure-free state, this has not been a uniform finding. A pre-surgical history of mood and anxiety disorder is associated with an increased risk of post-surgical depressive episodes in most studies. Ergo, when you do a pre-surgical evaluation, your evaluation is not complete if you haven't identified if these people have had a previous psychiatric history, particularly of depression and anxiety, because those are the patients who are at increased risk of developing these complications. How about post-surgical psychosis? Real phenomena. So these tabled summarize 4 studies. The numbers are smaller, and in general they've been reported in various case series in 3 to 35% with an average of 7 to 10%. They consist of hallucinations, paranoia, agitation or withdrawal, hostility, violence. Most patients with postoperative psychosis have family history of psychosis or other severe psychiatric disease. Again, we're seeing the same theme. If you look for a pre-surgical history of psychiatric illness or family psychiatric illness, it can give you some sense as to whether these patients could be at increased risk of this problem. And maybe more common in patients who are older at the time of surgery. In the 4 patients that we had, 2 of them remitted very quickly with the first pharmacologic intervention with second-generation neuroleptic medications. 1 patient had to be admitted twice to the psychiatric unit because he had persistent paranoid ideation. And I was part of the paranoid ideation. He thought that I was out to kill him. So I had to stop being his epileptologist and taking care of his seizure disorder. More common, they have been seen following right temporal lobectomy, and there is no clear correlation between postoperative seizure control and the development of de novo psychosis. There has been an association with the presence of what's known as alien tissue, which are small focal tumors in the form of hamartomas or dysembryoplastic neuroepitheliomas or cortical dysplasias. In the series of the Mosley in the UK, 23% of patients with alien tissue, in contrast to 5% of patients with mesotemporal sclerosis, had developed post-surgical psychosis. Other de novo psychiatric complications include manic and hypomanic episodes, and these are not that rare. They're probably under-recognized. It's not unusual for spouses to report that my husband is much more active in a way I've never used to see him. He stays up throughout the night fixing the kitchen appliances, becomes hypersexual. That's a common report. These are luckily relatively short in duration. And obviously the manic episodes are much more severe and required an intervention. Obsessive compulsive disorders have been reported as de novo complications, and also there have been a few cases in the literature, and all of them identified pre-surgical traits of obsessive tendencies or mild severity of obsessions or compulsions. And somatoform disorders are other expressions of post-surgical psychopathology in the form of pain syndromes, a variety of conversion disorders, different than psychogenic non-epileptic seizures. And in our series, we had 2 patients who had that, one of whom had persistent forms of a somatoform disorder. Now let me switch now to a new form of epilepsy surgery that we are using in the treatment of refractory temporal lobe epilepsy as well as focal dysplasias, which is MRI-guided stereotactic laser ablation of mesiotemporal structures. So MRI-guided laser ablation is a novel surgical technique for the treatment of intractable mesiotemporal lobe epilepsy. It basically consists of the burning, if you will, of determined tissue, in this case mesiotemporal structures, with laser. It's less invasive than resective surgery. It is associated with a very rapid recovery. Patients essentially go home the next day, and they go back to work the next week. And it has been found to be potentially less likely to cause post-surgical cognitive deficits. So the way it works is, here you have a probe that is brought in through MRI guidance into the mesiotemporal structures, and once it's in place, and you can see here the way it looks in a sagittal view and in a coronal view. Once it's in place, the computer calculates the volume and the temperatures, and the neurosurgeon can do several ablations in one sitting. And this is the way the tissue looks like. The post-ablation tissue looks like that. It's very nicely demarcated. In a way, it's like doing an amygdala hippocambectomy, but without touching the fibers. You're not cutting any fibers around it. And that is believed to be associated with the lack of some of the cognitive changes that we see after a temporal lobectomy. For example, patients who undergo a temporal lobectomy in the dominant hemisphere often will have naming difficulties. They'll have difficulty with recalling, what's that word, what's that word? And that can be quite disabling and persistent. We don't see that in these ablations. The other cognitive changes that are not seen in ablations are failure to recognize faces, which are seen very often after temporal resections. So we decided to look at the post-surgical complications in our case series of patients operated at the University of Miami in the last 2 years. The idea was to identify the prevalence of post-surgical psychiatric complications presenting as mood disorders following an MRI-guided laser ablation in mesiotemporal structures in patients with intractable temporal lobe epilepsy, and to identify the risk factors of these complications. So we had 17 patients. They were operated between November 2013 and May 2015. We wanted to make sure that they had at least a 6-month follow-up, because most post-surgical psychiatric complications following a temporal lobectomy present during the first 3 to 6 months. The presence of lifetime psychiatric history, past and current, was established in every patient at the time of the pre-surgical evaluation. And patients with current mood and anxiety disorders were treated prior to the surgical procedure. So when we discussed the patient in our patient management meeting, if it was established that that patient was symptomatic with ongoing mood, anxiety disorders, or other psychiatric symptoms, we would treat the patient and delay the ablation until the patient became asymptomatic. They were followed at 1 week, 4 weeks, 12 weeks, 15 weeks, 18 weeks, and 24 weeks after surgery. And at each visit, we established their seizure frequency, seizure type, cognitive and psychiatric symptoms, as well as any adverse events of anti-epileptic drugs. Our definition was similar to the ones that I gave you for the other study, but we classified the severity as mild if symptoms remitted with the first intervention within the first 6 weeks, or severe if the symptoms persisted for more than 2 months despite changes in therapy, and persistent if the patients were symptomatic at the last contact. So we had 17 patients, equally distributed between males and females. The mean age was 42 years. This is a group of patients who was older than the case series I showed you from Chicago, where the mean age was 30 years of age. These patients were 42 years of age. 7 patients were 50 years and older. And that's one of the nice things of the ablation, that it allows you to offer this kind of surgery to elderly people. And by elderly, by the way, I'm not meaning more than 50 years old. The site of ablation was 9 in the left and 8 in the right, so equally distributed. 1 patient had bilateral ictal foci with more than 90% of seizure originating from the ablated site, which had mesiotemporal sclerosis. The mean follow-up period was 17.5 months. with a range of 7 months to 25 months. None of the patients exhibited neurologic or neurosurgical complications after the ablation. And 15 of the 17 patients were discharged on day 2 at home. Notice that of the 17 patients, 12 had a lifetime history of psychiatric illness, so 70.6%, which is higher than the group of patients from Chicago, but these patients were older. The message here is patients who undergo pre-surgical evaluations are patients with an increased risk of psychiatric comorbidity. You're dealing with a group of patients in whom, if you look for the psychiatric comorbidity, you're going to find it. Now, the post-surgical mood disorders, we had 11 patients, so 64%, of which 6 were classified as mild, that was 35%. Severe, 5 patients, and persistent, 3 patients. So in 30% of patients, the severity of the symptoms was such that we needed to do several interventions to render the patients symptom-free. And in 3 patients, or close to 20%, symptoms persisted. Similar to what we were seeing in the temporal lobectomies, 30% of patients are expected to have post-surgical complications after a temporal lobectomy. Patients on antidepressants at the time of ablation were 6. And when I looked at the doses of the antidepressant medications, they were not high. But what this tells me is that being on an antidepressant per se does not prevent you from having a recurrence, at least at the doses that the patients were euthymic. If they were on higher doses, maybe that would be. And 4 of the 5 patients who had severe post-surgical depression were on antidepressants at the time of surgery. The type of mood disorders, 7 presented as a major depressive episode, 3 as a dysthymic-like episode, and 1 patient had a hypomanic episode. 3 patients had to be hospitalized in the psychiatric unit, accounting for 17% of all patients who underwent the ablation had to have a psychiatric admission. 2 because of severe suicidal ideation. When we looked at the relation between post-surgical mood disorder and pre-surgical psychiatric history and site of ablation, you can see that of the 11 patients with post-surgical depression, 10 had a pre-surgical history. Of the 5 patients with severe depression, 4 had a pre-surgical psychiatric history. And those patients with persistent psychiatric symptoms, all 3 patients had a pre-surgical psychiatric history. So again, the same theme. If you have a previous psychiatric history, you are at increased risk of having these kind of problems. In this group, the site of ablation was associated with an increased risk of post-surgical complications. 8 of the 11 patients who developed depression had their ablation in the left side. And all 5 patients and all 3 patients with severe and persistent depression respectively had their ablation on the left side. So for some reason here laterality appeared to be playing a role. The post-surgical outcome, seizure outcome, 12 patients were in a class 1 with 5 patients being class 1A, that is no seizures, no aura, 6 patients being class 1B, and 1 patient being class 1C. Then we had 2 patients who had a class 2, 2 patients at class 3, and 1 patient in whom the ablation had no effect whatsoever. When we looked at the association with post-surgical complication and seizure outcome, there was, as you can see here, no real difference. But most patients who were asymptomatic were more likely to fall in the class 1A and 1B categories. The numbers here are too small to really be able to make any significant, to reach any significant conclusions. When we looked at the relationship between post-surgical depression and anxiety and the severity of these mood disorders with seizure outcome, again, there's no difference, but again, the numbers are too small. So, what's the good news? Epilepsy surgery can improve pre-surgical psychiatric disorders. In the case, in the paper by Oren Davinsky, who reported on the post-surgical improvement of mood and anxiety disorders among the 5 centers that I alluded to before, 22% had depressive disorders only, and 9% after surgery were still presenting mood disorder. 18% were found to have anxiety disorders before surgery, and that dropped to 10%. And other psychiatric disorders were found in 4% of patients and were down to 1% at follow-up. When we looked at our own data from Chicago, so we started with 56% of patients who had a pre-surgical history of psychiatric disorders. At 2 years, that number went down to 37, so there was a drop by 34%. And at the last contact, it was down to 21 patients, so a drop of 2/3, 63%. The predictors of psychiatric improvement at 2 years and last contact were reaching a class 1A outcome. And this is for resections, or having auras was also associated. The other variables, such as the cause of temporal lobe epilepsy, duration of the seizure disorder, history of generalized tonic-clonic seizures, extent of resection of mesiotemporal structures, and neuropathologic abnormalities in the surgical specimen were not associated with improvement after surgery. So in conclusion, I hope that I convince you that psychiatric aspects of epilepsy are complex and their pathogenic mechanisms are yet to be established. As you can see, some patients got better, some patients got worse. And those that developed post-surgical psychopathology, some had de novo, some had a recurrence, some presented as psychotic episodes, some as mood and anxiety disorders. So it's a complex picture for which we don't have a clear understanding why it happens in some and not in others, except for saying that these are relatively frequent and are associated with a pre-surgical psychiatric history. And therefore, every surgical candidate should undergo a pre-surgical evaluation of a psychiatric history. A lifetime psychiatric history may herald a failure to achieve total seizure freedom, and this is a point that I did not review in this discussion, and this is a topic for another talk. So with this, I will stop, and if there are any questions, I'll be happy to answer. Thank you very much. Yes.
Wonderful talk. Thank you very much. When you're doing a pre-surgical evaluation and you sit down with the patient and family to get informed consent, given the way these patients are, and they may have some difficulty with mood or cognition, to what extent do you believe they really are able to give informed consent?
Yeah, so that's a very important question, because I personally think that if you are suffering from depression, or anxiety, you really are in no shape to give an informed consent objectively. And you're more likely, if you're depressed or anxious, you're more likely to say, I don't want to do this. So you may face, and that's one of the reasons that before we are sending the patients to see the neurosurgeon, we try to treat their psychiatric comorbidity. It is very important that when I sit with a patient, and I often will review all the potential complications of the surgery, I tell them essentially, you have a previous psychiatric history of depression and anxiety, so we need to be, you're not symptomatic right now, so we need to be very cautious. And these are the symptoms that you need to be looking for after surgery. And if they happen, you need to let me know. And then at that point, we would introduce medication or not. Sometimes, if patients have had recurrent episodes of depression, what I have done is I put them on an SSRI at low doses. And in my personal experience, and this is all anecdotal, this is for resections, they have had a better course. But when patients, when we discuss the psychiatric complications and the cognitive complications, it's very important that they have a clear understanding of what they're getting into, because if you don't tell them, and I often will go even further, I often tell them, okay, I'm telling you there is a 30%, but imagine you're among these 30%.
Ever seen a patient where you decide that the premorbid psychiatric history is such that you don't recommend the surgery, that the outcome might be worse, that is living with what you have may be better than taking a chance on surgery?
In general, my opinion is that if you, for a patient to be able to be a candidate for surgery, they have to have a clear understanding of the benefits and the limitations of the surgery. If they don't, they can't give you a proper consent. Now, for a patient to be able to undergo a pre-surgical evaluation and all that it takes, going through a VDG monitoring study, undergoing a high-resolution MRI studies, PET studies, and all those things, they have to have a clear understanding of what they're going to. And very often patients who are psychiatrically symptomatic may not be able to cooperate through this thing. And what we try to do is we work with our colleagues from psychiatry if their psychiatric disorder is severe enough that it requires a more intense intervention. Having said that, I'm a strong believer that the presence of psychiatric illness should not be a deterrent against surgery. So we have even offered surgery to patients with active psychosis, provided that they understand the limitations and the benefits of the surgery.
Have you ever tried ketamine on these intractable depressions? The ketamine in 45 minutes and you feel better for a few days?
I know my colleagues in psychiatry are using ketamine to treat refractory depression, but we don't. I have training in psychiatry, but I work as an epileptologist, so I feel comfortable taking care of the bread and butter. I will not manage, however, patients with bipolar illness who are suicidal or with severe personality disorders. And I don't think a neurologist should do that either. That's the, yes?
If I may quickly speak to that, ketamine doesn't really last. The antidepressant is great, but it doesn't last.
Right.
So that's one big issue. Hi, how are you? Thank you so much for a wonderful talk. I just have two quick questions.
Sure.
I'm a psychiatrist.
Veronica, do you mind?
Yes. Thank you. I'm with the psych department, and I have an interest in epilepsy and neuropsychiatry. And
My first question is, we actually use seizures, so to speak, to treat refractory depression when we do ECT. And I noticed that it seemed like patients who were seizure-free had fewer psychiatric complications. But I was wondering if you could speculate as to whether perhaps the reduction in seizures could have something to do with kind of the effect of kind of reducing the natural ECT-like mechanism of the brain to regulate itself against depression. So that's my first question. And then my other question is, for organ transplant, as psychiatrists, we often evaluate candidates and kind of pre-screen them, and I was wondering if maybe we should be more involved in pre-screening candidates for epilepsy surgery and then following them since there's such a huge prevalence of psychiatric disorders.
Yeah, so actually, so let me answer the second question first. I think because psychopathology in people with treatment-resistant epilepsy is very high, in the order, if you have epilepsy in general, if you take a group of, in the general population, 1 in 3 people will have a lifetime history of mood and anxiety disorder, 1 in 3. If you have a treatment-resistant, it goes up to 50%, 60%, depending on the study that you will. I personally think that every patient who comes to an epilepsy clinic should be screened for mood and anxiety disorders, period. And there are very easy ways of screening them. We have self-rating scales that take 3 minutes for the patients to complete, and which the neurologist can easily score and determine this patient is symptomatic with depression, this patient is symptomatic with anxiety. And the reason is because when you suffer from mood and anxiety disorder, it's going to have an impact on your seizure treatment.
Right.
Because if you're symptomatic with depression and anxiety, you're more likely to experience side effects from the anti-epileptic medications, you're less likely to be compliant, your memory is going to be more affected, your concentration is going to be more affected, and your overall quality of life. More problematic is you have an increased risk of committing suicide. And people with epilepsy, to begin with, have an increased risk of committing suicide. If you suffer from mood disorder, your risk of committing suicide goes up 42-fold. So we actually, in our clinic, give patients 2 screening instruments at every visit.
What do you guys use?
We use the NDDIE for identifying major depressive episodes. It's a 6-item instrument. If you score above 15, it has a high sensitivity and specificity. And the GAD-7 for anxiety. If you score above 10, and it takes less than 5 minutes for the patients to complete, and then you can follow them from visit to visit. So that's the one thing. For epilepsy surgery, definitely you have to, and that's one of the things that I insist. Every single patient needs to undergo a pre-surgical evaluation, because of what I showed you. You know, it's the lifetime history of these conditions that are likely to raise a red flag. Be careful with this chap. You know, he's at greater risk of. Now, the issue about ECT is a fascinating question, because it is an example of the complexity between epilepsy and psychiatric comorbidities. So I'll give you two scenarios. The first thing is that in some of these patients who develop very severe depression and become suicidal, they need to be treated with ECT. And now, on the other hand, ECT is an excellent anti-epileptic treatment. And we use ECT to treat refractory status epilepticus. So, you know, as a psychiatrist, when you bring the patient to the ECT lab on Monday, you elicit a seizure at X voltage. To elicit a seizure on Wednesday, you need to crank up the voltage, which means that your seizure threshold has gone up with the ECT given on Monday. And then the same thing happens on Friday, right? On the other hand, when we bring a patient to the monitoring unit, so when Dr. Kubiesi is doing a pre-surgical evaluation in his monitoring unit, patient comes into the monitoring unit, he stops the medication, patient has a seizure at 6 o'clock in the afternoon. He decides not to do anything about it because he needs several seizures. The next seizure occurs the next day. He doesn't give them anything. The next seizure happens 12 hours later. then 6 hours later, then 3 hours later. You see what I mean? So there is something very different about what ECT does and what spontaneous seizure do. It's complicated, and I don't have an intelligent answer to give you, but it's an area that probably is the expression of the fact that epilepsy and psychiatric disorders, particularly mood and anxiety disorders, share common pathogenic mechanisms. And it actually is quite fascinating because the common pathogenic mechanisms at the level of neurotransmitters are the same. So people with major depressions have high glutamate concentration in the cortex, low GABA concentrations, low serotonin binding in various structures in the brain that are in the same structures that there is low serotonin in people with temporal lobe epilepsy. So there is all these common pathogenic mechanisms that are shared by the two conditions.
Thank you.
One last question.
Okay.
Maybe. Do neuropsychologic variables, including verbal memory scores, visual memory scores, executive function, and others, predict the psychiatric, not the neuropsych? They do predict neuropsychology to a certain extent post-operatively, but do they predict psychiatric outcomes?
So they don't predict, but if you're suffering from depression, your cognitive performance is going to be affected, particularly in the domains of memory and concentration, because memory is been found to be one of the cardinal symptoms of somebody who is suffering a major depressive episode. And essentially, a depressive disorder is a limbic condition that affects frontal, temporal, mesial structures as well as subcortical structures. And there is a plethora of literature now that shows how with fMRI you can identify different areas that are activated in patients who are depressed, where you're testing a variety of cognitive functions, particularly memory and attention.
Great, thank you.